A very good morning, everyone. So today we discuss the periodontal medicine, CVS, and periodontal diseases. Content content include introduction, coronary heart diseases, atherosclerosis, periodontitis and systemic disease susceptibility, potential linkage mechanism for periodontal disease and MI, management of periodontal diseases in patient at high risk for atherosclerosis, conclusion and references. Objectives include to discuss about the concept of periomedicine, to discuss about the pathophysiology of cardiovascular diseases, to discuss about various common links between coronary heart diseases and periodontitis, to discuss about the management of periodontitis patient with coronary heart diseases. So what is periomedicine? It is a subdiscipline of periodontics that deals with non-plaque induced condition or lesions of periodontal tissues, including the periodontal manifestation of systemic diseases and syndrome. So, periodontal medicine, as suggested by Offenbacher in 1996, suggests that a rapidly emerging branch of periodontology focusing on wealth of new data, establishing a strong relationship between periodontal health or diseases. The interrelationship between the oral and systemic health has been a matter of debate since the controversial theory of focal infection by Dr. Miller. He stated that the oral pathogens had the capability to either directly enter or release their toxic products into the systemic circulation. In the past, a substantial part of focal infection was attributed to pulpal and periapical pathologies. Extensive research on the complex relationship between oral and systemic health has given rise to emerging field of periodontal medicine. The concept has evolved with considerable evidence linking periodontal status with systemic conditions including atherosclerosis, bacterial endocarditis, diabetes mellitus, and respiratory diseases. So this is the flowchart depicting the relationship between the microbial challenge, host immune inflammatory response, connective tissue and bone metabolism, and the clinical signs of disease initiation and progression. Conditions influenced by periodontal infection are coronary heart diseases and coronary heart diseases related events such as angina, infarction, atherosclerosis, stroke, diabetes mellitus, preterm labor, chronic obstructive pulmonary diseases. So we discuss about now the cardiovascular diseases. Cardiovascular diseases and in particular atherothrombotic disease causing coronary heart disease, stroke or peripheral arterial diseases remaining the leading cause of death. This periosystemic connection is of major current interest to periodontology. This is the flowchart of a coronary heart disease. Risk factor include acute or chronic. Acute include thromboembolism. Occlusion of coronary arteries leads to myocardial ischemia and leads to finally angina or myocardial infarction. If chronic persists, then it leads to atherosclerosis. It can be converted into narrowing of coronary arteries, or it can be occlude the coronary arteries also. Both leads to myocardial ischemia and leads to finally angina and myocardial infarction. So what is atherosclerosis? Atherosclerosis is a focal thickening of arterial intima, the innermost layer lining the vessel lumen and the media, and the thick layer under the intima consisting of smooth muscle, collagen and elastic fibers. It is a high inflammatory lesion. Dr. Russell Ross response to injury hypothesis of atherosclerosis states that the initial lesion results from injury to endothelium and leads to chronic inflammatory process in the artery. That healthy coronary arteries cross-sectional view first, and the second has a disease related cross-sectional view of the arteries. So attack of the bacteria, hypertension related diseases, homocysteine, smoking related causes, diabetes causes the endothelial dysfunction. It leads to thickening of the arterial lumen. Oxidized low density lipoprotein, cytokines, glycolylated end products, they also lead to thickening of the arterial lumen. And intercellular adhesion molecule ICAM1, endothelial leukocyte adhesion molecule 1, and vascular cell wall adhesion molecule 1 are also activated. VCAM1 leads to release activation of the MCP1. VCAM1 and the chemokine monocytic chemotactic protein 1 localizes monocysteine vessel wall. Low density lipids pass through the damaged endothelium into the vessel wall, and the low density lipids oxidize the vessel wall also. They are the foam cells that get formed due to the thickening of the endothelial lumen. Interleukin 6, 1, MMP, PGE2, tumor necrosis factor alpha, platelet derived growth factor, fibroblast growth factor also releases during this activation. Monocyte triggers chronic inflammatory reaction with lymphocytes, and this result in the tissue necrosis and fibrosis. Atheromatous plaque development, blood vessel wall becomes distended and continues to accumulate cholesterol. Some areas become calcified, as shown in this picture. Thrombotic development, coronary arteries with stable adenoma, inflammation, and necrosis have replaced the smooth muscle, but there is a dense layer inflammatory tissue. MMPs from macrophages and proteases from circulating bacteria can destroy collagen to form an unstable atheromatous plaque. Blood vessel wall can rupture and thrombus formation at a region of ulceration. Platelet aggregates on the exposed collagen. Thrombus formation. Circulating oral bacteria have peptides that cause platelet aggregation. Increased thrombosis can lead to sudden occlusion of the vessel wall. Coronary arteries occluded by thrombosis. Coronary arteries with narrow lumen and thrombosis. Periodontitis and systemic disease susceptibility. There are three ways of this. That is, first one is a shared risk factor. Second, subgingival biofilms, a reservoir of gram-negative bacteria, and periodontium, a reservoir of inflammatory mediators. Risk factors include not modifiable and modifiable. Not modifiable include gender, age, race, family history, hypertension, diabetes mellitus, body mass index, homocysteine, lipoprotein, a white blood cell, and fibrogen. And modifiable include lack of exercise, stress, alcohol consumption, diet, smoking, infection, C-reactive proteins. So increased viscosity of the blood, ischemic heart disease, and cerebrovascular accident stroke leads to plasma fibrinogen, plasma lipoproteins, LDL, VLDL, and the white blood cell activation leads to blood viscosity. Systemic infections are known to induce a hypercoagulable state and increase blood viscosity. Systemic or periodontal infection result in the activation or increase content of fibrinogen, increase white blood cell count, increase Wilbran factor, leads to blood viscosity, and it leads to finally ischemic heart diseases. Possible mechanism of association. Periodontal infection leads to gram-negative bacteremia or lipopolysaccharide activation. It leads to endothelial damage, platelet adhesion or aggregation, monocyte inflammation, infiltration or proliferation. It leads to cytokine growth factor production or thrombus formation. It leads to finally atheroma formation, vessel wall thickening, and thromboembolic events. Daily activity has mastication. That is, mastication and oral hygiene procedures result in the frequent bacteremia with oral organism. It is much more greater than from normal dental procedures. Periodontal disease may predispose the patient to virulent gram-negative organism. An estimated 8% of all cases of infective endocarditis are associated with periodontal or dental diseases, according to Drinkholt, MT, and Periodontal 1998. Diseases periodontium act as a reservoir of endotoxins. The concentration of endotoxins present was more than fourfold greater in those with periodontitis than in healthy subjects, according to Gates, Nis M. D. MP et al. JP 2002. So mechanisms are now emerging that suppose the hypothesis linking transient bacteremia common in periodontal disease causing endothelial dysfunction. Dental procedures creating bacteremia risk. Dental extraction, implant placement and tooth reimplantation, surgical and non-surgical periodontal procedures, endodontic instrumentation beyond the root apex or endodontic surgery, initial placement of orthodontic bands, interligamentary injection, prophylaxis when bleeding is suspected, subgingival placement of antibiotic fibers or strips. Dental procedures with low bacteremia risk, restorative procedures with or without retraction cord, local anesthesia, injection, placement of rubber dams, suture removal, placement of adjustment of orthodontic or removable prosthodontic appliances, oral impression, fluoride treatments, oral radiograph, shedding of primary teeth. Infection and atherosclerosis. Organisms include chlamydia, pneumonia, Helicobacter pylori, periodontal bacteria. Periodontal pathogens include cytomegalovirus. Periodontal pathogens in human carotid atheromas. 30% has a Treponema forsythia bacteria accumulation. 26% has a periodontal gingivalis. 18% has a AA comitans, and 14% has a Plasmodium intermedia. Rabbit model, that is Streptococcus sanguis and Plasmodium gingivalis, leads to platelet activation and aggregation through the expression of collagen like platelet aggregation and associated proteins. According to Herzberg and Weir 1996, the incidence of periodontal bacteria in atherosclerotic plaque by DNA analysis from 20 subjects was studied. Actinomycetic comitans, Clostridium rectus, fusiform nucleatum, Plasmodium gingivalis, Plasmodium intermedia, Treponema forsythia, and Treponema denticola. Plasmodium gingivalis causing cardiovascular diseases, atherosclerosis, arteriosclerotic aneurysm, peripheral arterial diseases, coronary heart diseases, heart valve of endocarditis, and Burgess diseases. This is the flowchart showing the endothelial activation and leads to some activation of all the enzymes on growth factor. Under normal physiologic condition, not possible for anaerobic bacteria to invade endothelial cells. However, direct invasion, endothelial function or structure is destroyed. Diabetes mellitus, hypertension, epilepsy, smoking, according to Hokamura et al. 2009. This is the flowchart showing the diagram showing the release of all the growth factors or the thickening of the lumen or intima. Research has clearly shown wide variation in host response to bacterial challenge. Patients with abnormality, exuberant inflammatory response often have a hyperinflammatory monocyte to macrophage phenotype. They secrete significantly increased levels of pro-inflammatory mediators, aggressive periodontitis, refractory periodontitis, and type 1 diabetes mellitus. This is the flowchart showing the atherosclerotic or vascular factors activation. Potential linkage mechanism for periodontal disease and MI. Evidence for the role of inflammatory mediators. Acute phase response defines a characteristic pattern of alteration in the concentration of plasma proteins that occurs following a different form of inflammation. Host encounters with pathogen, pro-inflammatory and anti-inflammatory effects. C-reactive proteins, interleukin 1, tumor necrosis factor alpha, fibrinogen, ICAM1, VCAM1, coagulation factor 8 activation, that is von Willebrand factors, serum amyloid A proteins. Evidence for the role of immunologic mechanisms. Immunologically competent cell types and products T and B cells, neutrophils, monocyte, macrophage, mast cell, immunoglobulin, complement immune complexes, and pro-inflammatory cytokines, heat shock proteins, interleukin 12. Potential linking mechanism. Microbial constituents of periodontal pathogens may induce 4 overlapping acute responses in the host. Direct interaction with host components including blood cells and heart tissue. Production of acute phase proteins. Innate immune response through cytokine mediators and stress defense including HSP expression. Studies reporting an association between periodontal disease and the cardiovascular disease that according to Matela et al. 1989, findings and conclusions are that is dental health significantly worse in patients with MI versus control after adjusting from smoking, social class, smoking, serum lipids, and diabetes. According to Beck et al. 2001, periodontitis may influence atheroma formation. According to Beck et al. 2005, presence of antibody to Clostridium rectus was associated with carotid atherosclerosis. According to Engbretson et al. 2005, severe periodontal bone loss was independently associated with carotid atherosclerosis. According to Ebnert et al., tooth loss was associated with an increased odds for death from myocardial infarction. Common genetic predisposition for periodontal disease and atherosclerosis. Beck and colleagues have provided a model proposing that there is a genetically determined hyperinflammatory monocyte macrophage phenotype in periodontal disease, increasing susceptibility for atherosclerosis. Blood markers for inflammation, interleukin 6 assessment, C-reactive protein assessment, WBC count, endothelial cell attachment, and IMT assessment. Management of periodontal diseases in patients at high risk for atherosclerosis. Patients at high risk for atherosclerotic disease should be subjected to complete periodontal examination. Patients that have periodontal disease should have a thorough medical history evaluating systemic conditions, medications, and risk factors for atherosclerosis and related conditions such as heart disease and stroke. Treatment of patient with periodontal disease and pre-existing atherosclerotic disease should be coordinated among health professionals to ensure that patients are adequately managed, taking into account medical as well as dental consideration and complications. Aggressive prevention of periodontal disease should be undertaken in patients at high risk for atherosclerotic diseases. Patients should be made completely aware of the possible relationship between heart diseases, stroke, and periodontal disease so that they may participate in the modification of risk factors such as smoking. Conclusion. It has been proven that a link exists between periodontal disease and cardiovascular disease. Periodontal disease is a risk factor for the future development of cardiovascular disease. The prevention and treatment of periodontal disease reduces the risk factor for cardiovascular diseases. Thank you.